Welcome to Heart of West Virginia, where we talk with experts from WVU Medicine about important health issues that many of us face, and hopefully give you valuable insights for your well-being. I'm Hoppy Kercheval, and today our focus is on heart disease. Cardiovascular disease is the number one cause of death worldwide, responsible for an estimated 18 million deaths a year around the globe. It includes heart attacks, strokes, heart failure, arrhythmias, artery disease, and more. It is a particular problem in West Virginia. Joining me to talk about this is Dr. George Sokos from the WVU School of Medicine, a cardiologist and chair of the cardiology department at WVU Medicine. Doctor, welcome.
Thank you for having me.
Good
Pleasure.
to have you here. Thank you. So I gave that pretty depressing information there.
You did.
But it is true about our state, isn't it?
It is. Unfortunately, we have some of the highest rates of, well, actually the highest rate in the U.S. with respect to cardiovascular disease. I think that stems from multiple factors. Unfortunately, we're one of the most obese states in the country. We have the highest smoking rate in the country. About 25% of our population smokes, which is astounding, not in a good way. And there's a lot of other factors at play with genetics and other things. But I would say let's start with the downer. But I think the positive is, we're making an impact. We're able to reach out to the communities across the state and really take a different approach to caring for people.
And I want to get to the positives. I think it's important to establish the baseline of the significance of the problem, and it's one that is not, it's one that really is spread across our state. And even if an individual is perfectly healthy, it could be somebody in their family or a friend or something like that. I think it's that extensive in West Virginia.
It is. I think it's access to healthier foods as well.
Mm-hmm.
We haven't talked about that. So there's those are things that we're working on with the West Virginia Extension Service and others. So and getting the word out is like what can people do to help themselves, not just what can we do to help, because it's different, right?
Right.
If I tell you what to do, but I don't help you help yourself, then I'm not really doing what I should be doing.
And sometimes by the time they get to you, a lot of damage is already done.
Correct. So we really want to try to get ahead of it and talking about prevention and how do we get ahead of things so we're seeing less. I'd like to put myself out of business, right? So that would be the ideal scenario.
Yeah. So we know what the risk factors are. What are the signs, though, that people should be aware of? That it's something more than that. It could be something worse.
Sure. So I think part of this is starting to interact with physicians earlier, and kind of being aware of things that can to look for, not only from how am I feeling, but what else puts me at risk, like hypertension, for example. Mm-hmm. We call it the silent killer because people feel fine until they don't. All right, and so long-standing untreated hypertension, people don't know unless you get your blood pressure checked. So some of the things that I talk about is it can be as simple as getting your blood pressure checked, getting some labs from your primary care physician, seeing your primary care physician. So those are some things to look for. But so once it gets past that point and we're start to develop coronary disease, people hear about chest pain and shortness of breath and swelling, so those are potentially signs of blockages in arteries in the heart. But there's also can be pain in your legs when you're walking, and not just from overdoing it, but like things that make you stop, and it goes away when you stop and then you start again. And those can be signs of blockages in the arteries in the legs. Mm-hmm. Obviously, we talk about stroke as another thing. Those can be weakness, numbness in your arms and extremities, slurred speech. Those sorts of things can be signs of stroke. There's lots of things that once it gets to that point to be aware of and not to ignore. Mm-hmm. So crushing chest pain, chest pain with exercise where you didn't have it before. It's not, people just talk, oh, chest pain, but no, it's not just that. It's, okay, last week I was able to do my regular walking, even just in the house or up the steps. And now when I do that, I start to have chest pain, shortness of breath. That's new. Okay, don't ignore that, right? People often alter their routines so that they don't have those symptoms anymore, So don't ignore it and try to get around one thing. So if you feel something's different, we'd rather you come to us and address it and look for things. And even if it's not there, then you can know that that's not what it is.
So what you're looking for? So what you're looking for is an aberration.
Correct.
Right.
Yeah.
Something that's not like it was.
Yeah.
Right?
Something that could happen suddenly or could happen over time.
Yeah.
It happens both ways.
Yeah. Yeah. And I think that's important to note, because there is a tendency, and maybe some of it's cultural, maybe some of it's just how we are. It's like, well, I'm fine.
Yeah.
I'm fine.
None of us want to face the fact that something could be wrong with us, right?
Right. Or maybe just having a blood pressure cuff and checking your blood pressure regularly.
Nothing would make me happier if people know what their blood pressure is, right?
Really?
Half the time I see my patients, like, do you know what your blood pressure runs at home? And they say, well, I don't check it. So sometimes it's because they can't afford a cuff, and we provide them with a cuff. It's a simple. They're not expensive.
So what's the number? Like I think the CDC just changed some information on blood pressure numbers for stroke risk. But what are numbers that if it's consistent that you should say, well, I better do something about that?
Yeah. So ideally, we'd like something. We'd like less than 120 over 80. That's a classic number that's out there, but that's still real.
Mm-hmm.
I would say when your systolic starts to get into the 130s consistently, it's the time to pay attention. And if your diastolic gets above 90, definitely time to pay attention to lower numbers. So I say systolic, that means the high number, and diastolic is a lower number. So when you start seeing those creep up over 130, it's time for us to make an effort to do something about it. Whether that's a lifestyle modification first, or a medication. I know people are hesitant to start on medications, but I can speak for myself. I was diagnosed with hypertension. I thought, let me try to do things myself.
Yeah. How'd that work out, doctor?
It worked out that I'm on a medication now, but now my blood pressure is normal. So
Okay.
So I think, and it's simple. It's taking a pill once a day. I know, again, who wants to take medications? No one. But who wants to have a stroke or a heart attack? No one.
Yeah. How big of a risk factor is smoking?
Smoking is probably the highest risk factor, modifiable risk factor that any of our patients can take care of. So that's what I tell all my patients. That's the one thing, even above changing your diet. Don't be wrong, diet's important, but if you stop smoking, that's even more important than changing your diet.
How about diet? How about diet, cholesterol management, those kinds of things?
Very important. I mean, so I think that's number 2.
Okay.
I would rather have someone gain some weight, a little bit of weight, and stop smoking than be skinny and smoke a bag a day, quite frankly. I mean, I'd rather have neither, but I'm saying if you ask me the two, I'd choose to stop smoking. But once we get to that fact, we get the smoking stopped, then we can focus on, okay, how do we really impact someone's everyday diet? That's why we have a team of professionals that work with us. You come walk into my clinic, you're going to see a dietitian and a pharmacist every time you walk in. Now, that's not every WVU Heart and Vascular Institute place, but we have those available everywhere, and it's important because understanding what you should and shouldn't eat and the quantities, super important.
Yeah. Doctor, the smoking is pretty straightforward. Okay.
Yeah.
So you shouldn't smoke. Try to stop smoking. It's hard to do. I think diet is a little bit more challenging because there's so many different kinds of foods. You don't always know what's bad for you necessarily.
Right.
And bad food is good. I mean, it tastes good.
It does. You go to the state fair. Look what's down there, right?
Yeah. And we know that a lot of foods that aren't good for us are marketed very heavily. So how do you change the mindset of folks?
Yeah, you're not going to do it all at once, right? I mean, I think you need to. You have to self-reflect. So we often tell people, okay, before we tell you what, we can give advice on what to eat and how to do it, but let's get an idea of what you actually are eating. Because I think if people would pay a little bit of attention to what they actually are eating and look at and then just keep a diary, and then you look at what that actually is in all that you just ate, it's pretty shocking. I keep a food diary.
Do you?
Yeah, I do. I think I've lost some weight. I felt like I wanted to be healthier. I want to be more active. And, I felt like I need to practice what I preach, right? So I do. I have just simple apps on your phone and, look, pay attention. And
Were you surprised?
Oh, my goodness.
That's what happens, right?
It's certainly, I'm speaking from experience. It certainly shocks you. And you're like, okie dokie. So,
What did you cut out that you think helped you and you needed to do? If you don't mind sharing.
No, I don't mind. So, I mean, processed food's probably the number one thing. That's very difficult though, because they're easy.
Yes.
They're easy access. We're all in a hurry.
Yes.
You know, you grab something at Sheetz or wherever, Little General, whatever because it's easy. Or fast food. You know, I cut out the majority of fast food. That's not realistic to tell someone not to have any fast food.
Right.
That's the first thing I tell my patients. Listen, I'm not telling you to eat vegetarian. I mean, one of my best friends is a preventive cardiologist somewhere else, hopefully here soon. She's vegetarian. She's actually vegan. And I said, you're not getting people to do that. You're just not. I'm glad you're doing it, but you're not. First of all, I'm not doing it.
Yeah.
Second of all, I know my patients, they're not doing it. But I think gathering of what to cut back, I'd say a lot of carbs. Carbs not all carbs are bad. It's just the wrong kind of carbs, right? And I'd say, fried foods still can have some. That's what I tell people. You can have some of these things. Just don't eat 4 pieces of fried chicken. You can cut that back and then make that a treat for you when you hit certain milestones.
Yeah. The hard thing is, and I try to watch carbs. I'm type 2 diabetic, and I try to watch what I eat. But you start reading labels, and you think, I didn't know there was that much sugar in there. I didn't know there was all those carbs in there.
Oh, yeah.
I didn't know. It is stunning how much sugar and carbs there are in all kinds of foods that you would not expect, and salt and such.
Yeah.
And just
it's the sodium.
Yeah.
My goodness. You think if you I'll pick on Chinese food, but it's why you're drinking several glasses of water afterwards, because you've consumed probably 4 days worth of sodium in one meal. And so
you have the and related to this, you have the lipid clinic, and what might somebody experience when they come to the clinic?
Yeah, so you can expect, again, to meet a pharmacist, to meet a dietitian, and to meet a nurse practitioner or physician assistant, as well as a physician. So it's a larger intake. So there's a lot of blood work. There's understanding if most of the time people have tried. By the time they get to our lipid clinic, they've tried other medications, or PCPs tried something with them, and they've not gotten to the goals of what they wanted to. Sometimes we talk about doing genetic testing, because there's familial hyperlipidemia, we call it, which is basically inherited high cholesterol. And so simple things don't work for that. You could eat as well as you want, and it's not going to get it to where you need it to get to.
Thanks, Mom and Dad.
Yeah, right, exactly.
Yeah.
But I mean, we have several medications, whether they're pills or we have injectable medications now that really lower that cholesterol where it needs to be.
It sounds like, Doctor, you're talking about just a more holistic approach to the individual. Is here's some things, whether it's medication or diet or lifestyle or any number of things, to try to improve the patient rather than just take this pill or have the surgery or whatever.
Yeah,
that's fair.
That's extremely fair. That's exactly what we want. We want to make an impact that it's not just a one-time thing, right? You want something that's sustainable, just like anything else.
You're doing clinical trials here, is that correct?
We are.
What are you doing?
So actually, several trials related to, let's focus on cholesterol for a second. So multiple different new medications out there right now trying to lower cholesterol. There's people, maybe you've heard of it or not, like LP little a's as lipoprotein A. That's a newer marker that we're looking at. The new guidelines recommend that people have that checked at least once in their lifetime to understand. That's another molecule in the blood that we can assess risk. So that puts people at a higher risk for developing coronary disease. And within the next year, we're going to have clinical trials looking at medications, trying to lower that. Most likely of those will be focused on something we call secondary prevention, which means you've already had an event, like you've had a heart attack or something happened to you before. And we're trying to prove that just lowering that molecule, lowering the amount of that molecule in your blood is actually helpful. Right now, we know, okay, we're at higher risk, so we do whatever we can to lower cholesterol as much as we can, and not necessarily measuring that molecule again. So new trials will be looking at all that stuff. Those are things that my preventive cardiologists do on a day-to-day basis. That's not me, but that's my colleagues, and they're the devil's in the details there. Those guys are all over that,
Yeah.
and ladies for that matter.
Yeah, yeah. Are there any silver bullets out there?
No, I think, people, I'll say that the number one complaint I get is people come into my office and saying, I don't want to be on a statin. They hear all these side effects about, statins like Lipitor or atorvastatin or Crestor or rosuvastatin's the other name for it. And they definitely have side effects. I'm not saying that those medications don't have side effects, but I think it's not nearly as high as people are concerned about. They are life-saving medications. They prevent heart disease. They prevent repeat heart disease. They are extremely effective. They work. They are easy to take.
So what's the resistance then?
So, well, there's a lot out there. If you people read on the internet, and there's some things as far as like, I get a lot of muscle aches, and that can happen. There's a side effect that can cause inflammation in the muscles and break down the muscles. But it's not as common as people think it is. Mm-hmm. And I think people sometimes wrongly attribute some of their muscle aches to the medication. Now, mm-hmm. there are times where absolutely it does it, but I think don't be scared of it. If we can adjust, we can go a different direction. There are other medications that we can use, but they're cheaper. They're all generic. We can use them, and so all the insurance companies will cover them. Their copays are low, and it's life altering.
What cutting edge testing and technology do you use that goes beyond the
beyond
physical?
Blood work? Yeah. So, first thing we do is we're looking at blood work. We're looking at the cholesterol. We've discussed that.
Yeah.
We're good with that. So, there's other testing that we can do. We do things such as CT scans of the heart. Mm-hmm. So we're looking at calcium scores. When you have elevated levels of calcium within the arteries in the heart, it shows up on a CAT scan or a CT scan, and can help us understand the risk of developing, of having plaque there, or which when I say plaque, that means basically blockages within the arteries in the heart. And if that level's high, then we could think about doing another type of CT scan where we use dye. So we call it a CT angiography. It's kind of like a heart catheterization without the invasiveness.
Okay.
It's not exactly the same, but it's very similar. We can see the anatomy very well. And when we do that, we work with a few companies. We send out that information, and we do analysis of the amount of plaque in the vessels, and gives us a better idea. Do we need to do something about it? Do you need a heart catheterization where we would do something about that? Mm-hmm. Do we need to think about, do you need to have bypass surgery? Most of the time people are having some symptoms, and we're looking at that just when we go to that step. But that's really cool technology where particularly with those folks who have a higher risk from a family history and from other things, looking at that information can help us understand how aggressive we want to be with prevention.
Now, I would think that the conversations with someone who just needs to make lifestyle changes or quit smoking, that's one thing, and I think that's pretty straightforward. How do you have the conversation with somebody who's at the next step, where you're going to have an invasive procedure, or maybe in an extreme circumstance have them wait for a heart transplant? How do you have that conversation with them in a frank way, but also with a reasonable bedside manner on what is very scary for that individual?
Yeah, I think the most important thing is honesty. I think I am, if you ask my patients what I do well, is I put it in terms they can understand. I lay it all out there for them. I lay the options of where we are, and what's the next few things that we can do, and what we're going to do if we find something. We may do the test and not find something, but if we do find something, what do we do next? And then I personally spell it out. Okay, we can do, if it's minimal, here's the least thing that we could do, and here's the worst case scenario. My day job is a heart failure. I treat patients with heart failure and who may need to go into transplant. When I see them, I talk about how medications are our first step, and my job is to keep them away from needing a heart transplant or a heart pump or anything that is invasive and that last resort. But you have to lay out all the in between, and you got to lay out a timeline of what we think and why we want to be aggressive with what we're doing. Most people, they're scared when they hear that, right? They should be. I would be. I mean, and I know about it, right? So that you're going to be anxious, but it calms people to understand what they could be going through and what they're going to see and what could happen to them.
Mm-hmm.
And that knowing that you have the expertise and the team around you to deliver that care appropriately and to really ensure them that you have their back. You're ready for the worst case scenario. That's how I explain it.
Mm-hmm. You give them hope, but not false hope.
Yeah, I mean, you have to be honest. And if there's no hope, if you come to a point where we can't do anything, that's the worst conversation I have to have.
And you've had those
multiple times. Unfortunately, I'm usually the gatekeeper between some patients and passing away. Unfortunately.
Yeah, but then let's circle back to the beginning. So somebody's listening and they're thinking, well, I have some of these habits. Diet, lack of exercise, smoking, and I've got some things going on. I mean, what are they? Because the tendency is to avoid.
Yes, I would say don't be afraid. We're here to walk you through it. We can help. There are things that we can do to help people to quit smoking. There are things that we can do to help alleviate your fears. We talk through those things, and again, that's why it's not just me. It's not just the physician. That's why we have a team. People need to talk to all those folks on our team to help get through that and to help understand and navigate where to go next.
Mm-hmm. Why are you here?
Love it. I'm from West Virginia. I wouldn't be anywhere else. I sell West Virginia to people to come here. I recruit other physicians to come here. I think it's a special place, not just, the people are special because I know that we're those people, right?
Mm-hmm.
But I think what we have here at WVU Medicine is different.
Because
I think the people make the difference. I think the attitude makes the difference. I think the commitment to delivering care. People say, "Oh, you're just talking lip service that you're committed to the people of West Virginia." That's not true. People who come here for a reason. They see how special it is. They see how dedicated we are to people. They see we mean it.
Mm-hmm.
Not just.
And it's a big, imposing place, and it can be scary. Maybe it is scary, but they shouldn't be afraid to come here.
Not at all. I would tell you, I think that when you walk up to the door, you're going to get greeted by someone. They're going to welcome you and they're going to help you. You don't need to be. It is. People talk about, get worried about coming to Morgantown with the traffic and everything else, particularly tomorrow probably. But people are extremely welcoming. I can tell you a story. I had a physician, good friend of mine. He lives in Atlanta. He flew here to come. He came here to visit us to see what we're doing. So he is in charge of a committee that I'm on, looking at disparities in care. Particularly, I'm in charge of this on a national committee for rural health care and cardiovascular medicine. And he came here to see what we're doing. So he flew in here, didn't get here till midnight, was at the airport. He looked at his phone, no Uber, no taxi, and he's sitting there in the airport. And a couple that was on the plane with him came up to him and said, "Do you need a ride?" He's looking at it, he goes, "I think I do." And so they had no idea who he was, and took him down to the Marriott. And he said, "This is the most, I've never experienced that anywhere else, because you guys got something special going on here."
It's true. West Virginia you can get a ride in West Virginia, right?
You can. But I thought that was, he says, "I will never forget you guys for that." He goes,
wow.
Yeah.
But I think that is indicative of the culture here, which is not just at the airport; it permeates the state, and it's particularly true at this hospital.
I agree with you. It's not. It's not isolated. It's a real thing, and people who come here and get their care, they'll tell you that. They'll tell you how they felt that way, and that the team really is giving and caring. And then you can't fake that.
Right. Thank you, Doctor.
Yeah, thank you.
Appreciate it. Dr. Sokos, thank you very much. If you'd like more information on the topic, visit wvumedicine.org/heart, wvumedicine.org/heart, and be sure to continue to follow us for more important health information. For producer Chad Ploche Atkins, I'm Hoppy Kercheval, and thank you for joining us.